my colleagues, I'd like to invite our next speaker, our next speaker is another committed physician, a good friend of us in the Emirates Thoracic Society. Professor Martin Kolb from Canada is with us in his early morning hours. Professor Martin Kolb is the Moran Compel Chair and Professor in Respiratory Medicine and Director of the Division of Respirology at the McMaster University in Hamilton, Canada, Ontario. His major research interest is in the interstitial lung disease. So we are switching gears now from chronic airway disease into interstitial lung disease. He has authored more than 130 peer-reviewed publications in different topics related to ILD. He is the chief editor of the European Respiratory Journal. It's an honor and pleasure to have Professor Kolb with us today, who's gonna talk to us about the management of interstitial lung disease. As you may know, there have been new tools and options for treatment of ILD in the world of pulmonary fibrosis. Professor Martin Kolb, good morning to you and welcome to this event.
Hello, Professor Ashraf. Pleasure as always to speak to you, to speak to the audience here. And of course, it's an honor to follow Professor Singh, who is an expert in COPD and one of our associate editors of the ERJ. So today, assuming that not everyone in the audience is an ILD expert, I want to give you a mix of some didactic information about interstitial lung disease and also novel therapies that are emerging. My disclosure slide is here, so I'm obviously consulting some companies who develop products in this field. And I want to start with a case presentation just to set the stage. So this is a gentleman who I've taken care of. I saw him first 2 years ago, 58-year-old man who was short of breath, had a bit of cough. He had some crackles on exam, and he had a mild restriction in his lung function with about 80% predicted lung volumes. And there was really nothing suspicious in his history that would have pointed to anything of relevance. His image back 2 years ago looked like this. You see peripheral reticulation, you see some areas that look like ground glass opacities, but certainly not dominant. You see no honeycombing, and that pattern would in our ILD terminology be described as indeterminate for usual interstitial pneumonia. The gentleman, as I said, had very little symptoms, was not eager to go for a lung biopsy, and we just observed him. 2 years later, he felt more breathless. He had a similar degree of cough, and he lost about 440 milliliter lung volumes. And that means in 2 years, he lost about 10 times more lung volume than you would lose by just aging. And this is one of the typical signs of anyone who has fibrotic progressive interstitial lung disease. He was at that time then, based on this image, diagnosed with idiopathic pulmonary fibrosis. You see now, compared to the previous picture, no ground glass opacity anymore. You see traction bronchiectasis, and you see the beginning of what we call honeycombing. So this is a relatively typical picture that's described as usual interstitial pneumonia. He started anti-fibrotic therapy. He picked Nintedanib over pirfenidone for personal reasons, and he tolerated that quite well. On December 4, which is just 2 months ago, he still had no change. He tolerated the drug well, and we could not do a spirometry at that time because of COVID restrictions. Now, just 2 weeks later, he called and he said he has much more breathlessness developing over just a week. That happened at rest, not just at exertion. His oxygen saturation was decreased to 84%. He had no fever. COVID and other viral swabs were done and they were negative. And you see in this image here, done December 22, that he has no developing ground glass opacities in the lungs. They are patchy. There is much more extensive honeycombing. He was put on intensive care unit, and another 2 weeks later, January 4 this year, so just 4 weeks ago, He had diffuse ground glass opacities, and sadly enough, a day later, he passed away. So this is just giving you an example of interstitial lung disease and how unpredictable and bad it can behave. And this gives us obviously a lot of reasons to manage these patients much more aggressively than in the past. If you want to manage a patient properly, you need to establish a diagnosis at first. And there are a number of guideline documents. I highlight here the Canadian Thoracic Society document about how to come up with a diagnosis. This gives you relatively good guidance of what to do in real life, in practice, what kind of blood tests to do, what kind of imaging to do, what kind of intervals you would get a patient for reassessment. And ultimately, the purpose of these approaches is to put a patient into a box, and that box has a name. And in interstitial lung disease, we have about 200 of these boxes. So we have to find out which box a patient belongs to. And this has a major implication on how we manage these patients, whether we call it idiopathic interstitial pneumonia or autoimmune interstitial lung disease or hypersensitivity pneumonitis or sarcoidosis or anything else. Now, we heard in the last decade or 15 years primarily about IPF. The reason being that IPF was the disease that was studied in large clinical trials. There were about 15 to 20,000 patients enrolled in clinical trials, which is quite remarkable for a rare disease. But in a specialty clinic like mine, IPF is only about a quarter of what we do. So that means that 3/4 of patients have different disorders, and this is a group that we have not really focused on. Just to reiterate some of the different types, exposures can cause interstitial lung disease. Obviously, asbestosis is an interstitial lung disease, or coal miner disease. You can get different hard metal disorders as well. If you have organic exposures, such as pharma antigens, like mold in hay, for instance, or bird-related antigens, you get hypersensitivity pneumonitis. And hypersensitivity pneumonitis is right now in this year and last year very much in the focus because there was a lack of guidance documents of what to do. There was a lack of understanding, and these two articles are certainly very good documents to read up if you want to refresh your memory about how to diagnose hypersensitivity pneumonitis and what are the pathogenetic concepts. But ultimately, this is a highly inflammatory disease at the beginning with forming of non-necrotizing granulomas in the lungs. And these granulomas are often located in the small airways. And when you block a small airway, you get air trapping. And this is what we see in an image called mosaic attenuation. This is a picture in inspiration, and mosaic means you get different shades of gray. And if you get this patient to expire and do an image, then you see that this mosaicism, these different types of gray, are much more profound. So this is a very, very classic example of hypersensitivity pneumonitis. You always should keep drug toxicity in mind, and it's nowadays not only the classical ones like amiodarone or bleomycin or nitrofurantoin. It's increasing the biologics, checkpoint inhibitors that we use in cancer therapy that can cause a very wide range of interstitial lung abnormalities on an image that are to be managed, of course. Connective tissue disorders are very important. And in terms of interstitial lung disease, we particularly speak about rheumatoid arthritis here, where ILD happens in about 10 to 15% of patients with clinical impact, and systemic sclerosis is a rare disease, but it affects the lungs very often, and it can be managed nowadays as well. Now, my case in the beginning had IPF, and IPF is still the most detrimental of these disorders. What IPF does, it causes a progressive shrinking of the lungs that's not predictable in its development, and acute exacerbations, just like the one that ended the life of my patient, are rapid, unexplained, and unpredictable. And IPF, I always say it's a rare disease if you look at the whole population. But if you look at the population that is important in IPF, so the patient 60 years and older, it happens there's a prevalence of about 200 to 250 per 100,000, which means that an internist, given the aging population and change in demographics, will very likely meet these patients and see these patients. So you should be aware of them. And it is a benign disease by biology. It is not a benign disease when you look at survival. If you compare IPF with the most common cancers that affect patients these days, you will see that in regard to 5-year survival rate, it is the 3rd worst cancer. Only lung cancer and pancreatic cancer are worse than IPF. Now, when I simplify the approach to these complex groups of disorders and think about clinical management, you would, of course, ask the question, why would you put all this effort into separating them into those 200 different entities? You can make it a bit easier and just put these 3 streams in here. If you diagnose a patient with IPF, you have access to anti-fibrotic therapies. They're called pirfenidone and Nintedanib, and they have shown to change lung function loss and likely also affect mortality. We'll come to that in a minute. If you diagnose hypersensitivity pneumonitis, you will have access to anti-inflammatories, and you will, of course, need to counsel the patient about avoiding antigens. So someone who has bird fans in your lung should avoid birds, not only by avoiding living birds, but you should also look at your pillows, whether they have feather pillows in there or duvets or anything else that would have bird feathers as a ingredient. And if you have connective tissue disorders, scleroderma, polymyositis, rheumatoid arthritis, you would also use immunosuppressants. And I will show you the data as well in a minute. You can consider anti-fibrotics for any of these disorders if they behave like IPF. Lung function is important to determine progression, and the primary outcome used in clinical trials, this is where all the literature is forced vital capacity. Does not mean that in your clinical practice you should not do measurements of gas transfer, and diffusing capacity is a very useful marker to monitor disease progression in your individual patient. And of course, if you think about interstitial lung disease, there is nothing that would prevent you from becoming an expert in CT scanning and in reading CT scans. And what you look for is changes of fibrosis, reticulation, honeycombing, and traction bronchiectasis in the periphery. And there are important documents published that I would encourage you to read up, because they give you a good set of descriptors for these changes and good examples. And if you have not the specific experience, you would, of course, seek help from expert centers. Now, let's think about treatment. And the question is really, in these disorders, interstitial lung diseases, should you treat immunosuppression or anti-fibrotics? What should you use, and when should you start it? Now, you should try to go away from this box thinking. So instead of thinking about those 200 different entities, we would think about, how does a disease behave? Is it reversible and self-limited? That would be, for instance, smoker-induced interstitial lung disease. If you stop smoking, they often reverse to normal. Hypersensitivity pneumonitis can reverse to normal if you avoid the antigen. There are some diseases that have fibrosis, but they are not progressive. So there you would just want to maintain the status. And there is a big group of interstitial lung diseases that are irreversible and progressive. And there you want to slow the progression. And we have very little evidence for immunosuppressive therapy in any of these interstitial lung diseases. We all use them. We all give patients steroids. We all give patients azathioprine or mycophenolate, but there is not much evidence there that they actually work. This evidence is based on single center, retrospective, non-randomized trials. And in this field, if you want to boost your knowledge, this is a very good narrative review from the Mayo Clinic, where you can see exactly what kind of immunosuppressants would be used in these patients and what the level of evidence is and what should you do to monitor clinical side effects. So this is a very useful document for clinicians. This document also highlights the scarcity of the evidence. Indeed, rheumatoid arthritis that most people would treat with immunosuppressants, there is not a single randomized controlled trial ever done. So everything that's out there is expert evidence and expert recommendation, but nothing really in terms of trials. The exception is scleroderma, interstitial lung disease, where you have a pretty good body of literature using azathioprine, using cyclophosphamide, mycophenolate, rituximab, and lately also anti-fibrotics. Now, when you think about progressive disease, if it's IPF, like in this example, or non-IPF pulmonary fibrosis, we know that these patients progressively lose lung function. You lose lung function because your lungs shrink due to scarring. If you age above age 50, 55, you lose about 20 milliliter or 30 milliliter FVC per year. If you have one of these fibrotic lung diseases, you lose about 200 to 300 milliliter per year, which is 10 times more quick than you would have it by aging. And of course, if you think 1 year, 200 milliliter, that's not much. If you think 5 years, that patient will have lost 1 liter. If you start with 3 liters, being a small individual, for instance, you are down to 2 liters after just 5 years. And this is very significant. So what you want to do is, if you ideally want to stop that, of course, in a futuristic world, you want to make it better, but scar is not easy to get away from the lungs. So what you want to do at least is slow it down. And this is something that the treatment guidelines for IPF incorporate in the recommendations. And I want you just to look at the drugs that are recommended as treatment for IPF. Lung transplant, oxygen are obvious, but there are 3 different drugs that are recommended as a treatment for IPF. The one is antacids, because they probably reduce exacerbations, and the 2 antifibrotics called Nintedanib and pirfenidone. And what these 2 drugs have done is in clinical trials is they have shown that you reduce the loss of lung function over a 1-year period by about 50%. So they don't stop it, but they reduce it by half. And instead of losing 1 liter in 5 years, when you're on these drugs, you would lose just half a liter in 5 years, which is a very impressive development and finding. These drugs are now on the market for about 5 to 6 years, and we are eagerly awaiting the first studies that look at mortality impact in an epidemiological scale. I'm pretty confident that our dismal survival rate of 3 to 4 years will look better the next time we see a study being published. Now, pirfenidone is a drug that interferes with scar formation on different levels. It reduces scar-forming cells like fibroblasts. It reduces the cytokines that these cells use to talk to each other and to stimulate each other. And it has been clearly shown that if you reduce lung function loss over time, in the pirfenidone trials, you improve mortality rates. And that's very, very impactful and powerful. Nintedanib is a drug that interferes with fibroblast proliferation. It's a tyrosine kinase inhibitor. Similar drugs are used in cancer biology and in cancer treatment. And by doing this, by stopping the growth of these fibroblasts, you reduce the loss of lung function. And that happens relatively quickly. So in a trial, as early as 3 months after starting, you will see the effect of drugs like Nintedanib on the FVC in this patient cohort. And very important, it does not matter if you have well-preserved or normal lung function, or if you have very severely impaired lung function. The slope is the same. A patient who starts normal will lose 200 milliliter per year. A patient that has already 50% of predicted at the start will lose 200 milliliter per year. And by treating patients with these drugs, you will reduce that by 50%. Now, nothing is free in life, and obviously these drugs have a financial cost, and they also have an adverse effect profile. And the good thing is here that there is very little serious side effects to be seen with anti-fibrotics. So nothing that we would know from treating patients with steroids or other immunosuppressants. There's no tendency to get more pneumonias or heart attacks or osteoporosis. What these drugs can do is quite unpleasant. They can cause diarrhea, which is very typical of Nintedanib. They can cause nausea, weight loss, and skin rash, which is more commonly seen in pirfenidone. The side effect profile is often what determines my decision together with my patients of what drug to use, because patients may have preference, and this is what I often use as a guidance of which drug to use. Now, at the end, I just want to tell you about diseases that behave exactly like that, IPF, but that are not IPF. And those are disorders that we know are important. They're about 1/4 of the patients I see in my practice. They have progressive disease behaving like IPF, but it's not IPF. And these patients were to date not allowed to be treated with anti-fibrotics. And this is something that was addressed in this trial that was published about a year ago in the New England Journal. And this tested the drug Nintedanib, anti-fibrotic, in progressive fibrosing interstitial lung disease that behaved like IPF, but that was not IPF. And what this shows is exactly the same as we've seen from IPF trials. You see that these patients lose about 200 to 300 milliliter FVC per year if they receive placebo. So exactly the same disease behavior. If you treat them with Nintedanib, they reduce that loss to about 100 milliliter per year. About 50% of the loss is gone when you treat them with anti-fibrotics. And this is extremely important, and this has led to this drug getting approved in many countries in the world. Not all of the countries yet, but it's been approved in the United States, in Europe, in Canada, and other countries. Pirfenidone also affects non-IPF pulmonary fibrosis. That was shown in this one trial, which is the last one I will show you. That was called the unclassifiable progressive fibrosis. That's the disease that, despite doing a multidisciplinary discussion, the physicians cannot come up with a unifying diagnosis, but we know that they behave similarly bad as IPF. And if you treat these patients with pirfenidone, they will also benefit from that intervention. So this is my last slide, and I just want you to get this as a new concept when you think about managing patients with interstitial lung disease. You should think about what causes it, because if you identify an exposure, you could counsel the patient and give the patient advice how to avoid it. If you see inflammation, you would want to treat this with anti-inflammatories. Keep in mind that there's not much evidence. And if you have fibrosis, you should treat fibrosis, because that would not respond to anti-inflammation. So IPF would be the prototype fibrotic disease. It's fibrosis from the start to the end, and you only treat that with anti-fibrotics. We know that steroids are not good for IPF. If you have connective tissue disease or autoimmune interstitial lung disease, you will have a beginning with some inflammation. You may want to do lavages to see whether there is inflammatory cells, and you may want to treat them with anti-inflammatories. If patients are progressive, you should consider anti-fibrotics, and the same is true for hypersensitivity pneumonitis. So don't think you get by asking all these questions about exposures, because you still can counsel a patient about exposures. If a patient has flares with inflammation, you may want to consider anti-inflammatories. Again, keep in mind the evidence level is pretty low. If you have fibrosis that drives the progression of patients with hypersensitivity pneumonitis, you should treat them with anti-fibrotics. And with that, I am happy to give the microphone back to my friend, Professor Ashraf, and happy to entertain any questions. Thank you.
Professor Kolb, for your overview. And we have a couple of questions on the topic. As you nicely outlined, interstitial lung disease is caused by different causes. One of the colleagues is asking about the prognosis being different from one trigger of ILD to the other. Would you like to briefly tell us how is the prognosis different depending on the cause of the ILD?
Yeah, so that, if you have an acute ILD, the prognosis is usually good. So acute hypersensitivity pneumonitis, that has a good prognosis. If you have something acute or like chronic like cryptogenic organizing pneumonia, which often comes after drug exposures, or could also come, I mean, that's, when you think about COVID and interstitial lung disease, cryptogenic organizing pneumonia or organizing pneumonia is a quite common pattern. And that's usually responsive to steroids and has a good prognosis. If you just think about the different types of progressive fibrosing interstitial lung diseases, there's also a different behavior there. So chronic hypersensitivity pneumonitis seems to behave similar to IPF, and so does rheumatoid arthritis with that IPF-like pattern. Others have a much better prognosis. So I think it's very important to make that distinction. But I think as a general rule, anyone who has progressive fibrotic interstitial lung disease, the prognosis is not very good.
Is interstitial lung disease reversible depending on the cause? Can it be reversible?
Yeah, so I mean, as I said, the more acute it is, the more likely you will reverse it. If you have a lot of scar tissue, you will not have the same opportunity to reverse your lung disease. I think it's important to look down to the histological level. Yeah. So organizing pneumonia is a disease where you see a lot of patches and confluent opacities in an image. And if you look at the tissue level, this is all a lot of fibroblasts and other inflammatory cells, macrophages, but there's not much scar tissue. There's not much matrix, right? Once you lay down matrix, so collagen, fibronectin, proteoglycans, and once they destroy the architecture, that's not reversible anymore.
Thank you. One question comes on hypersensitivity pneumonitis. If you're lucky enough to diagnose somebody with acute hypersensitivity pneumonitis and you manage to start them on treatment with steroids, for example, how long do you give them steroids and which agent would you use to spare them from steroids?
First of all, if you clearly identify the trigger, you don't need any treatment. That sometimes, let's say in the classical case, that would be the pharma, or I mean, a patient of me, I've seen him like 2-3 years ago. He was in a community hospital, always treated for pneumonia and asthma, but he had a barn, he had a hobby, he was a hobby farmer. He did some work in his barn, which was about 50 yards from his house. And every time he went into that barn, he came back with fever, cough, and couldn't breathe for a few days. I don't know why this wasn't picked up, but when he told me the story, I said, well, just don't go into that barn because it causes hypersensitivity pneumonitis. And he had exactly that picture of mosaic attenuation. So that guy would be fine when you just avoid the barn or just wear a respirator when you go in there. If you have more difficulties avoiding that, let's say you get acute HB because your neighbor has pigeons breeding in his backyard. So those feathers, of course, if your neighbor is not cooperative with you and doesn't want to give away his birds, then you will be exposed. See, it's very hard to avoid the exposure. Then you would treat with steroids. And I would usually give 0.5 milligram per kilogram for a month and then wean down. And if you want a steroid sparing agent, you would add anything that you're comfortable with. It could be azathioprine, could be mycophenolate, could be sometimes even methotrexate.
Thank you. Thank you very much. And the common question at each topic of respiratory today, COVID vaccine and ILD. Is it safe to give COVID vaccine to the ILD patient?
Yeah, so I think I concur with Professor Ward, what he said before. There is not much evidence for it, but we absolutely recommend the vaccine to any of our patients. Yeah, so I mean, with COVID and ILD, first of all, there seems to be less patients with ILD getting COVID. The reason is likely that they are already primed over many clinic visits that they should avoid any viral problems, right? So they are aware of it. They would follow social distancing rules and would do that just right. So they get it less often. However, if they get it, they are much more likely to get a more severe course. And also die at a higher rate. Yeah, so there's one study showing that patients admitted to the hospital with COVID who have ILD, their mortality rate in the hospital may be up to 40%, and age-matched patients who have no ILD, their death rate is about 20% after being admitted. Yeah, so yes, absolutely to getting vaccinated.
Sure. And patient who gets ILD after COVID, so fibrosis post-COVID, and what's the role of OFEV or any other anti-fibrotic agents? We don't know a lot about this. Would you consider this for post-COVID fibrosis?
Well, it's a good question, right? So, I mean, there's a lot of noise about post-COVID problems. There's not as much evidence as noise. And so you can imagine for the ERJ, we get a lot of papers now on post-COVID impairment of lung function or persistent changes in an image, including ILD. The longest of these observations is now 6 months old. Mostly it's 4 months. And that's just way too early to say anything definitely. Yeah. So if you have bad ARDS, you often see these remnants of ground glass opacity, some reticulation. Yes, there are clear cases of honeycombing that has developed, but those are case report territory. So it's not reflective of the 20 million people in the world who have been diagnosed with COVID already. So we don't really know, but it's enough to say we should monitor them, we should stay alert. And yes, if fibrotic changes develop post-COVID, OFEV Nintedanib might be an option. There is one trial addressing this question going on in France. I don't know how quick they are in recruitment, but it's a good question. Yeah, but I would just stay there with curiosity, but not anxiousness if I address that question.
Yes, you did. Thank you. And how many patients, what's the percentage of COVID patients in your observation from your center at least develop ILD? You said ground glass, you said few developed honeycomb. Do you have percentages? Were there any audits in your center?
No, but I mean, yeah, this needs multi-center, large studies, and they are underway. Yeah, I mean, there are different, so they are underway, but before we can give any idea about what percentage would have this, we need more time and we need more numbers. Yeah, so I think most of the studies that I've seen so far, looking at lung function after COVID, the majority point to deconditioning rather to a true cardiopulmonary limitation. But it's not impossible. So we have to get the data and we have to stay vigilant and do whatever comes.
Thank you very much, Professor Kolb. It's been a pleasure meeting with you today. And thank you very much for enlightening us in this important topic. Thank you very much.
Pleasure is all mine. Take care.
Take care. Thank you very much.